One of the very few agents that actually enhance slow wave sleep. Well, I'm all for that. Another drug which works very well is mirtazapine or Remeron, which is an antidepressant. If you want antidepressant action, you're actually looking at 45 milligrams up to 60 milligrams POQHS. In very low doses, however, it's sedating. In fact, it's more sedating in the lower doses. So 7.5 milligrams up to 15 milligrams POQHS is very efficacious for insomnia. Caution here, there's a lot of weight gain with this particular drug. So the patients that I prescribe this with, actually I use that side effect profile to my advantage and the patient's advantage. This is a great choice for individuals who look, if you will, failure to thrive. These are the individuals, their appetite's falling off, they've lost weight, their albumin, pre-albumin is low, borderline, and so they're kind of going down that failure to thrive type of pathway. This drug will pack on the weight. So again, this is a side effect profile you can use to your advantage. So 3 drugs worth your consideration: doxepin, which is Sinequan, gabapentin, Neurontin, mirtazapine, or Remeron. Again, it's not a one-size-fits-all. So you want to be very careful and very judicious about their use, but they do have their place given the chronic conditions the patient's experiencing. Well, something I should say about over-the-counters and other herbals. Of course, all my little old people love their Tylenol PM because of their, and they like their Benadryl because they like the diphenhydramine. Well, we really don't like it for sleep, and the reason is because it causes even worsening of cognitive function, cognitive abilities. So they're kind of hungover the next day, they're not sleeping very well. Another herbal, though, besides melatonin, worth your consideration is valerian. American Family Practice did a very nice Cochrane review of valerian. Very sedating, and 300 to 600 milligrams POQHS. A very good option also if the patient has restless leg, and they did a nice little review of that, an option. Valerian we think of as, thank you, 10 minutes, as an anti-anxiety agent. Works actually quite well. As far as non-pharmacological interventions, I will tell you that cognitive behavioral therapy, hands down, is most efficacious, more efficacious than pharmaceuticals. Cognitive behavioral therapy with the elder population for the treatment of sleep disorders is hugely effective. One of the studies I looked at, fairly recent, and I was glad to see it, looked at the outcomes of cognitive behavioral therapy 2 years later, and the gains that patients made still held. People were still sleeping better. Cognitive behavioral therapy addresses lifestyle modifications, patient education about normal sleep architecture and normal changes with aging. Also sleep restriction. You want to sleep better? Don't go to bed at 9 o'clock and toss and turn and wait for 3 hours before you go to sleep. Go to bed when you're sleepy. Sounds like common sense, right? Go to bed when you're sleepy. If you're not asleep in 20 minutes, get up, do something relaxing. These are the kinds of techniques that work, and they work very well, and without the dangerous side effect profile of reduced cognition, falls, ataxia, and so forth. Also, reconditioning and stimulus control. You know what you're supposed to do in your bed? You're supposed to sleep or have sex, or both, but nothing else. Don't read in bed, don't watch TV in bed. I tell my nursing students, don't study in bed. And they pile their beds with books and papers. The other techniques that work quite well that is a part of cognitive behavioral therapy is using relaxation techniques, also music therapy, the delta wave stimulation that I shared with you as you were having your lunch. Also alpha stim, very effective. Alpha stimulation is that very nice, relaxing state of mind that you have after you have an exercise class or you do yoga and you're just kind of in that Zen mode, you know, that feel good, oh, I just feel wonderful. That's alpha wave activity. You can purchase alpha wave stimulation music, delta stimulation music. I have a whole pile of these kinds of CDs designed to get me into the mood of whatever it is I need to do. Cognitive behavioral therapy also addresses the vicious cycle of anxiety and depression that ensues when people have chronic insomnia. So people go to bed at night and they, oh my gosh, I'm never going to sleep tonight. And they get into a fight with the bed, they get into a fight with the bedroom, increasing their anxiety and further worsening their insomnia. Cognitive behavioral therapy breaks that lock. Changing thoughts, negative thoughts about sleep, negative thoughts about the bedroom, and emphasizes sleep hygiene. Hygiene referring not to cleanliness, but best practices. For years, I was a home health nurse. I was in Southwest Missouri. I covered 4 states, Oklahoma, Kansas, Arkansas, and Missouri. Treated a lot of psychiatric patients, went to their homes. Well, psychiatric patients have a lot of sleep disorders. And you know what they all had in common? I got to see a lot of bedrooms. And I got to see a lot of bedrooms that were very poorly ventilated, too well lit, cluttered, messy, not conducive to sleep. These are the kinds of issues that's addressed in cognitive behavioral therapy. One of the other best practices for sleep hygiene, and I get asked this a lot, is about napping. Well, the thinking has always been 1 nap a day, no more than 30 minutes, the power nap. Actually, the literature now is saying napping is highly individualistic. Yeah, you can get too much, but it's really up to you. Warm baths do work, and the reason it works is because it reduces core body temperature. Why do you get sleepy at night? Not just because melatonin levels rise. Why do you get sleepy at night? Because your core body temperature drops. And it goes up during the day, during the daylight, when we're supposed to be active. When you work all night, you're out of sync with your own core body temperature. There's a transient dip in the middle of the day between 2 and 4 p.m. Core body temperature drops. So that's why you get sleepy in the afternoon. So when you watch a commercial and it says, "Are you tired in the afternoon?" Yeah, I'm alive. Between 2 and 4 in the afternoon, it's perfectly normal to feel sleepy, and then you'll perk up later. A great way to treat that normal physiology, as well as the advanced phase shifting, is bright light therapy. Numerous bright lights are available. They're commercially available. You want a bright light that has 10,000 lux. I've been asked recently about the efficacy of blue light therapy. Blue light is actually what's used by the astronauts in outer space. So NASA puts blue light in the capsules to keep the astronauts with their circadian rhythm of sleep-wake cycle. Well, there was a study that came out just very recently that indicated a correlation between blue light therapy and macular degeneration. So now there's kind of a hold and, oh, we better take a look at the blue light. But the traditional white light, bright light therapy is very efficacious. I have a light lamp. My husband and I, we put it on our breakfast table in the winter. We have our breakfast, we expose ourselves to our 10,000 lux for 30 minutes, and then we go about our day, feeling a little bit better, less lethargic. This is the treatment for seasonal affective disorder, for example. Okay? So how do you treat the advanced phase shifting situation where the person wants to go to sleep at 7:30 at night? You know what you do? You get out a light. You put it on the table between 2 and 4 when the core body temperature drops, when they're getting sleepy, and then you get a second dose of light exposure at that time of the day. Generally, the person then can stay up, and they're up till 9 or 10, more of what their normal sleep pattern would be like. And then they don't miss out on anything, no loss of function. Bright light therapy is very effective. Make sure if you're to pursue this and you want to look at what's commercially available, you do get bright light that filters out the UVA and the UVB. A great study, and I think we should do, those of us in long-term care, and I see a lot of people here, we need to do a bright light study in long-term care facilities. There are indications for bright light therapy in the treatment of agitation, wandering, the confusional arousals. So as the dementia progresses, bright light therapy might be an option for these patients. Well, I've got some resources that I compiled for you. The National Sleep Foundation, this is a great place. If you just look at one website, I would recommend that you look here. Professionals, paraprofessionals, the layperson. This is where I downloaded the sleep log or the sleep diary. You can use that for your patients. There's also great patient-friendly, downloadable for free information on sleep hygiene. The National Institute on Aging, great website for garden variety issues related to all aspects of aging. The American Academy of Sleep Medicine, it's really more for physicians, but those of you who are into blogging, you might want to look at this site. I know there's some people into blogging. They have a great sleep education blog that's open to everyone, and I've looked on that. It's kind of fun. There's a new program coming out of the University of Virginia. It's called Shut Eye. This is cognitive behavioral therapy by way of the internet. So for people who cannot get out and find a CBT group, that's the idea. I put in a call to them, a call twice. The program is not up and running. It's supposed to be running in July of this year. So this would be a great website for you to look at. Well, my favorite resources for nurses and nurse practitioners, of course, is the Hartford Institute for Geriatric Nursing. You can download the screening assessments that I mentioned, the Epworth Sleepiness Scale. Also, the Pittsburgh Sleep Quality Index is available free. No cost to you at all. For local community behavioral therapy, I want to share with you what's going on at St. Vincent Behavioral Health. There's a neuropsychologist, Dr. Becky Davis, and Mr. Mike Nichols. He's a licensed clinical social worker. They do a great job. You do not need a physician referral. And they're doing a super job leading these groups in CBT. For a medication review, I would refer you to Assess Prescription. This is a free service. Carla Cobb, who's with us today, she's a pharmacist at Riverstone, and her specialty is psychiatric medications. She's actually been instrumental in pulling this program together. If you have a loved one or you have a list of medications that you want reviewed, start there. And I know I've gone through a lot of material and I'm out of time, but I think maybe we can take maybe one question or possibly two. I'll be around, but yes, there is a question.
I was wondering if that bright light therapy has been tested on people with sundowners?
The question is whether bright light therapy has been tested on individuals with sundown. Yes, it has, and it has been. There's been some efficacy, not a lot of studies, but actually the recommendation is for bright light therapy with patients who have a dementia process, and it can help treat that agitation, what we call agitation, that's predictable with the sundowning. It can help with that. Well, we're out of time. I see people at the door. Thank you very much for your attention.